Dr. Mundozie's residency was at St. Elizabeth's Hospital in Belleville, and he also worked at Scott Air Force Base Hospital, as well as the Cardinal Glennon Children's Hospital in St. Louis. Additional areas of specialties include child and adolescent care, occupational medicine, patient education and advocacy, preventive care, and weight management. Dr. Mundozie is a fellow of the American Academy of Family Physicians as well. So super excited to introduce Dr. Mundozie. Thanks again.
Hi, thank you, Patrick. Hi, everyone. I'm Dr. Mundozie. I work at MercyHealth here in Harvard. I've been in practice for about 18 years now. I would like to thank the whole organization at Elderwerks, the sponsors, as well as the participants. So thank you for giving us the time. Today, we're going to show you a video that has been recorded, so we don't have any technical issues. And that's about Parkinson's disease. So I will take questions if you have any at the end, but I will be live throughout the presentation.
Thank you. I'm going to go ahead and hit play. No technical difficulties. Hold on one moment, please. Let's see.
Viquar Mundozie. I'm the family practice physician for MercyHealth here in Harvard, Illinois. I will be talking today about Parkinson's disease. As you can see from the slides here, we're going to talk about the diagnosis, the management, does dementia always occur in Parkinson's, and also living with Parkinson's. I just want to mention I have no conflict of interest in any of the presentation or any information that is being presented. So just FYI. So just a background about Parkinson's disease. Parkinson's disease, why we are talking about it today is because it's one of the most common neurological disorder that affects 1% of the individuals older than 60 years. The incidence, as you can see, is 4.5 to 21 cases per 100,000 per year, and the prevalence is about 120 cases per 100,000 per year. It's more frequent in men, about 1.5 times more than the females. Most cases of Parkinson's disease, the cause is idiopathic. That's what we call it, but we really don't know. The hypothesis is it could be a combination of genetics and environmental factors. There's no specific confirmed studies regarding the environmental, but the hypothesis is it could be pesticides, it could be people living in rural areas, near the chemical plants, near the nuclear plants, but there's no proof about that, but that's the hypothesis. 10% of the cases are genetic, and that's more common in younger generation. We can still find, we'll talk more about it in the coming slides. So the diagnosis, Parkinson's disease is a clinical diagnosis. I want you to be, stress. I cannot stress enough this part. It's a clinical diagnosis, and there's no lab markers or MRIs or tests or PET scans or anything that we use as of now to diagnose Parkinson's disease. So it's very important that whenever you see some signs or symptoms that you go see a clinician, because that's where the diagnosis is going to come. You need to have two of these three signs, the clinical signs that I have highlighted. The number one is the resting tremor, number two is the rigidity, and the three is bradykinesia, and we'll talk more about this. The fourth cardinal sign, which is speculated, but you don't need that to diagnose, is the postural instability or balance difficulty, and that's more in advanced stage. Usually we see that after 8 or 10 years of the diagnosis. So the initial clinical symptoms that we're going to talk about, the number one is asymmetric resting tremor. Now I want you to understand that because that's the main reason why patients come in and see the clinicians. And so it's very important that you understand that particular sign. So the resting tremor simply means you're having tremor when you're at rest. So it's not like when you're reaching out to something that you're having more tremor like this, but when you're resting, that you're having tremor. That's the classical symptoms. And usually it's on one hand, where the Parkinson usually starts. That's why it's called asymmetric, meaning that it's not symmetric in both hands at the same time. So whenever you see those, it could be other causes, but mostly the resting tremor is because of Parkinson's. Now moving on to the next one is you can also see some decreased dexterity, especially in golfers. You can see this. Like when they're playing golfing, they're not able to hit the ball properly. They're not able to score as good as they used to be. Also, complex activities like dressing, putting on your clothes, you can see that. So anything that involves coordination of the arms, needs a complex physical activity, so you can see that. Like decreased arm swings, that we just mentioned about. Now the next one is the soft voice. So somebody who is talking normally suddenly starts kind of softer and the voice kind of goes slowly. That's another sign that you might want to keep an eye on. The next one is the masked face. We call this because they suddenly have decreased facial expression. That's why we call it masked face. They can also have sleep disturbance. Usually it's the insomnia that we see. There's another one called RBD, which is a REM sleep. It's a sleep pattern. Usually we have a couple come in and the spouse says, my husband, he's been acting out in sleep. He's been kicking me, he's been crying, he's been shouting. That's a phenomenon, because when you go in deep sleep, your body is supposed to be atonic. Basically, you have to be like flaccid, but that doesn't happen. They start acting out. So that's one of the signs that you might want to think about. Decreased sense of smell, that's another one. And these signs and symptoms are divided into motor, which is mostly the case, and also autonomic. That's a different neurological system where they can exhibit constipation, excess sweating, and sexual dysfunction, which we'll talk about later. Basically, I want you to know, Parkinson's, if you want to know, it just slows you down. So if you look at all these, it's just slowing you down. So a normal person who's been active, who's been, acting normally, slowly slowing down and shaking, and you'll see more signs. They'll be stooping down like this with a shuffling gait, small steps. They will have, depression is pretty common, and we'll talk more about dementia. That can also, this is a different category that can happen too in later part. So same thing, resting tremor, we talked about it. When you're sitting and then resting, the tremor can happen. If we do the finger nose test, where the patient touches my finger and then they do quickly, that's like intentional tremor. Like when you're trying to reach something, you can have a tremor. That's called kinetic tremor. Mostly other conditions can cause that. It's not a resting tremor, but some of the patients can display both. So I just want you to be aware of. Rigidity, basically the passive movements, like when you're moving, it kind of becomes rigid. There are two types. One is the lead pipe, where slow rigidity, and then the cog wheel, where there's like a little bit cog wheeling, as you want to call it. Bradykinesia, basically slowness of the movements. The handwriting will change, decreased facial expressions, more held writing, soft speech, and even the blinking rate can slow down. So those are the few of the things that you might want to take a note of and remember. Postural instability, that's the one that comes in late, and where things get debilitated, and there's a high risk of fall when that happens. And then the next one is the laryngeal dysfunction and dysphagia. That's an important one because that affects your speech, and slowness of the speech, the tone decreases. You can ask the patients to use sustained vowel phonation, and the voice diminishes. They can have increased breathing when they're talking, a little hoarse. One thing to remember is when the speech is slowed down in a Parkinson's patient, when you say, can you say it again? When you say twice as louder, they are able to do it. So the speech therapy is important. Most of the time, physicians or the patients, they don't think about speech, and they don't go see a speech therapist because they think the medications are going to help the speech. In fact, they don't. And I think later on today, you're going to hear from one of the speech therapists, and he's going to talk to you a little bit more about that part. So if you can, make sure you listen to him. Dysphagia, obviously inability to swallow or difficulty swallowing, can be seen in advanced Parkinson's disease as well. And it can range from drooling to risk of aspiration. So autonomic dysfunctions like orthostatic hypotension, your blood pressure falls when you're standing up. Constipation, we talked about sexual dysfunction. So those are the common factors. Cardiopulmonary impairment, that's rare though, but it can happen when they're stooping forward at the advanced stage. So. Now we're going to talk a little bit about dementia here as well. So dementia, that can happen along with Parkinson's. And how you would know is usually when patients come in, they're forgetful, and then we test them. Usually we do mini mental status exam, but in particular Parkinson's disease, the Montreal cognitive assessment is better, where it's pretty much similar with this 30 questions or activities that you have to do. 26 and above, if you're able to do it or answer, you're fine. But with mild cognition, that's the better test. As you can see in the study that they did, 64% MOCA compared to 54% MMSE for the diagnosis. The prevalence of dementia ranges from 20 to 40%, and with the disease conferring 2 to 6-fold increased risk compared to the normal population. And most of these patients have some executive impairment, like organization skills, things like that, which an executive would probably might want to stay on top of. And usually this is seen in the advanced stage, which is like around 8 to 10 years. So we talked about it occurs late in Parkinson. That's important. And if the dementia is occurring within the first year of being diagnosed with Parkinson's, that's not the real Parkinson's dementia. It's more like a Lewy body dementia, which is a different condition, kind of similar to Parkinson's, but it's a little different, where you see Lewy bodies in the brain when they do the MRIs and other things. The other factors, when you have dementia, the other factors to think about is stroke. It could be Alzheimer's ischemic stroke. And also the prevalence in these patients of depression is very common. So that's another thing you might want to remember about. Now, the executive function, short-term memory loss, and the visuospatial ability may be impaired. But in these patients, the aphasia, the linguistic, the speech problem is not present. So that's something that you might want to remember. Okay, so the Parkinson's disease is a clinical diagnosis, no lab markers, anything is needed, and no routine finding is needed unless you're thinking about some other cause of the tremors and other conditions. The patient with an unusual presentation, you're not sure about Parkinson, is where most of the physicians will do the diagnosis, do the workup, do the labs, and other things like serum ceruloplasmin. They do that for Wilson's disease. They can do olfactory testing because of the hyperosmia, but mostly it's a clinical diagnosis. Now, let's move on to the management. So the management there's the early stage management and the advanced stage management. Most of the focus is on the early stage. So it's crucial that you diagnose the patients early, and so that we can start the treatment to slow down the symptoms and improve their functional ability so they can still try to live as much normal life as possible. So there's 3 groups where you can see the main one is Sinemet, often called levodopa, which is kind of used along with carbidopa. Then there is MAOB inhibitors. There's a different class that we sometimes use, and there is a dopamine agonist. So 3 main. There's other ones too, but we're going to talk about it. So the levodopa, which has been used for a long time, along with the carbidopa, remains the standard of choice, and because it provides the greatest anti-Parkinson, greatest benefit with the least side effects, especially early. In the advanced stage, it can cause, it might not be as beneficial, and we're going to talk about it soon. So the combination is Sinemet. It comes as a immediate release or the delayed release form. And they do come in combinations with other medications called cont inhibitors, which are used usually in the advanced Parkinson's disease. The usual starting dose comes around 300, 600 a day, which is kind of divided into 3 to 4 times a day, depending on the functional ability of the patient and how to control the symptoms as the days progresses. Always in the patients start low and go slow. So usually we start in a low dose and then slowly titrate based on the symptoms. The common side effects is the increased risk of dyskinesia. It's like a different movement, abnormal movement. We're going to talk about more later on. Very common to see nausea. So when the patients start, they say, "Doc, I'm having nausea, I can't take this medication." So usually I tell them to take it immediately after the meal, and that seems to help and take care of the nausea for the most part. The other symptoms are dizziness, headache, confusion, delusion, hallucinations that can happen, especially if you're elderly and if you already have some cognitive deficit. The MAOB usually is the Selgilin, Resagilin. These medications can be used initially for mild symptoms without the use of Sinemet, or they can be added later on. They're pretty safe, that's why we use them, less side effects. Selgilin is indicated as adjunct therapy, usually 5 milligrams every morning, max of 10. And Resagilin is indicated for the treatment as an initial monotherapy. So you can start with 1 milligram, and in the later part you can kind of cut it down to half to 1 milligram along with the other medications. Side effects: nausea, headache, dizziness, pretty much the same. So the initial treatment with the dopamine agonist that we talked about, to which the levodopa can be added, is associated with fewer motor fluctuations, dyskinesia, than levodopa alone. So basically these medications, when you add them, they kind of cut down the later side effects of the initial medications. Now, the dopamine agonists are pramipexole and repinirole, Requip, like we used to call it. We usually like to call it. They provide symptomatic benefit that is comparable to Sinemet in the early disease, but these agents lack the sufficient efficacy to control the signs and symptoms by themselves in more advanced disease. So basically they're used initially, later part, then they don't have as much role. They're commonly reserved for younger patients, somebody who's less than 70, they don't have the side effect of cognitive impairment because these can cause hallucinations and other side effects. Like you see, the most common adverse effect is nausea, hallucinations, somnolence, impulse control disorder. The impulse control disorder, it can happen. They just go, on a spending spell. They can be hypersexual, and those can be side effects that you want to watch when these patients are on those medications. And they usually resolve. Once you reduce the dose, the side effects can resolve, or when you have to stop them, then the side effects usually go away. So continuation, they can be used for patients who have disability due to tremors and then are not adequately controlled. Then you can try these medications. The most common used anticholinergic agents, which is a different group, is the trihexyphenidyl. Also, you can use benzotropin, which is cogentin. And that's titrated slowly, start low and go up on the dose slowly. Another one is Amantadine, which is an antiviral medication, but we can use it. It has some anti-Parkinson's effect. We don't know why, but some people use it. And again, the same thing, the side effect can be confusion and hallucinations, so you have to be careful when you're using these medications. So, now this is the advanced stage. When you have advanced stage, you have motor fluctuations, wherein the medications, they don't work as good as they used to work in the early part. So when we're using the levodopa-carbidopa combination, the Sinemet, initially in the early stages, the medication starts and then it lasts, the immediate release one can last for 4 hours. And then that's why we dose more frequently to keep the medication in your blood. And that's what is called the on time, meaning the on-off phenomena, we call it, meaning the medication is on and it's working for their symptoms. And when the medication is not in the system, when you start having these symptoms, rigidity, tremors get increased, that's an off phenomena. So the on and the off. Now over time, as the disease progresses, the window kind of closes down. So instead of 4 hours, 6 hours benefit with the morning dose, it's cut down to 2 hours. So within 2 hours, 3 hours, the patient say, hey, my tremors are back. That's the fluctuation that we see as the disease progresses. And we're going to talk about how to, later on, how to correct that. Usually we use control release formulation. We use different infusion medications that are there. We can use inhaled ones. We can add on different medications. The newer one, it's called Neurans, a selective adenosine, which has been recently approved by the FDA. Dyskinesia. That's another symptoms that happens in the advanced stage, which is like a twisting, turning movement when the medication reaches its peak. So that's another side effect we see in the advanced stage. So when you give the medication is peaking, and patients exhibit these kind of abnormal movements. So now we have another problem compounded to what we're already dealing with. And that's where, when you're adjusting the dose, you want to make sure that the side effect of dyskinesia is minimized. And at the same time, you don't want to keep the dose so low that it's not benefiting the tremors and rigidity of Parkinson's. So that kind of in the advanced stage kind of becomes kind of tricky. So the goal is to maximize, the symptoms without troublesome dyskinesia to improve the function. So that is the goal, is to keep them more functional as much as possible, especially in the advanced stages, so that they can have a quality of life. Okay, I like this one. I hope you recognize this guy, Michael J. Fox. I often say now I don't have any choice whether or not I have Parkinson's, but surrounding that non-choice is a million other choices that I can make. So he's always been very positive about things. So we're going to talk about a little bit about the goal of the treatment. We already mentioned is to keep it functional. I'm going to go a little bit faster here because this new COMT inhibitors are there, just FYI. TASMAR, you have to monitor liver function because of the hepatotoxicity. COMT, you don't have to. There's extended release Amantadine available now. Now, the putative neuroprotective prescription or the treatment is where the treatment can slow down or stop the disease. For Parkinson's, there's nothing like that. There's no proven treatment that stops the disease. There was trials says the vitamin E CoQ is not beneficial. Okay, moving on to surgical treatment. The most important now, a new thing is the deep brain stimulation where, reversible wires go into your brain, they stimulate, they can adjust and see how depending on the response. It's actually more favorable now because you don't see the side effects like you see with levodopa and medication. So this is something new that's very interesting and it's coming up that has kind of replaced the other surgeries that we used to do. Gene therapy, neuronal transplantation, these are all in research. Another one, Muhammad Ali. God gave me Parkinson's syndrome to show me I'm not the greatest. He is. This guy, used to say he was the greatest, but the Parkinson's can. Old age, greater severity of motor symptoms, if they're having a lot of motor symptoms, and having mild cognitive impairment. Those are the risk factors. It's estimated about 50 to 80% of Parkinson's will eventually have dementia. So something to kind of keep an eye on. They say that usually it happens after 10 years of being diagnosed with Parkinson's. Additional risk factors, if you're having hallucinations during, basically like cognitive impairment, like excessive daytime sleepiness. You can have freezing episodes, like where patients want to do something and then they just stop. So they just freeze, and that can be a high risk for falls. So common reported symptoms in the Parkinson's dementia: changes in memory, obviously concentration, judgment, trouble interpretation of visual information, muffled speech, visual hallucinations, delusions, depression, irritability, sleep disturbance can happen. This same thing, no single test, no combination of tests that conclusively determines the person with dementia related to Parkinson's disease. One thing, a little guideline here is the Parkinson's dementia is based on the symptoms, but it appears after 1 year of diagnosis for Parkinson's disease. So if somebody's having dementia to begin with, or within that first year of Parkinson's disease, then that's Lewy body dementia. It's not related to Parkinson's dementia. So that's something you might want to remember. Outcomes are the same. It's a chronic disease, progressive. No treatment to slow or stop the brain cell damage caused by the Parkinson's dementia. Things we use for Alzheimer's, we try that, cholinesterase inhibitors, antipsychotic medications if they have behavioral problems, but a lot of side effects. Now, deep brain stimulation is contraindicated in this kind of Parkinson's dementia, so that's something you might want to remember. Depression is very common, we use SSRIs. If they have sleep disorders, we use clonazepam, Klonopin. Okay, moving on. It's a very important topic. We don't have much time, but I'll try to do as best as I can. Living with Parkinson, somebody having Parkinson, okay? It's hard when you're early on to kind of accept that. You have to go through different emotions, okay? And there's a lot of changes need to be done in your life, that things you used to do, you can't do anymore. And it progresses, so you need a lot of support. So there's no diet in particular that is recommended. You just have to eat healthy, like everybody else, lots of vegetables, fruits, well hydration. Certain challenges, we're having nausea, take the meals after you take the levodopa. You know, you can have difficulty swallowing, nausea, that can impair your intake. So that's something you might want to consider talking to your physician. Try to eat more easily digestible food, fruits, vegetables, mashed potatoes, soup, things like that. Foods which are in high water content because you can get dehydrated. Watermelon, you know, things like that. Beverages, celery, really good one. Emotional health. So when you get hit by something like chronic diagnosis, things are not the same way. It's kind of emotional toll, and you need to accept it, go through the emotions, know that, it takes time. You can be in denial, you can be angry, you can have different relationship issues, so you need to kind of work. Feel free to talk to your doctor about seeing a counselor. Nothing wrong with that. Set a short-term goals, take few things, take one day at a time. That's what I usually tell my patients, take one day at a time. So we're going to talk about the activities of daily living. I'm going to flip through a few things they can see right in yellow. Work with the occupational therapist. Mobility is slowed down, so have a set schedule. Go for walks, dance, call for help. Parkinson's Foundation is here to help you. You can use canes, walkers, wheelchairs. So they make separate ones for Parkinson's patients because of the physical thing. You can talk to the physical therapist, occupational therapist. They'll do all the measurements, and depending on other medications and side effects and medical problems, they'll recommend. The canes they recommend is a straight cane with a rubber tip. Avoid the ones which has tripod because of the freezing and other things you can fall. Walkers, try to get the 4-wheel walker. Big wheels, you can maneuver hopefully with a seat and a basket, so you can even fold it and take it wherever you're going. Wheelchairs, same thing. Avoid the standard ones, get the lightweight wheelchairs. That can happen as the stages advance. Freezing is a temporary involuntary inability, that makes you having a risk of fall. So usually when patients are turning, when they're moving, walking, slow steps, and they want to turn or they want to sit down, is where this happens. They just freeze and they fall. 38% of the people living with the Parkinson's fall each year. That's a high number. And especially when you're old, chance of hip fracture, bedridden, long-term care, that with all the complications can happen. Home safety, big one. General, floors should be clean. Get rid of the carpets, things that you can fall, cords, good lighting, wide walking spaces. Don't have much clutter, only the things that you need, especially in the areas where you're dining, with living areas where you're moving. Bedroom, same thing, well lighted. You're going to get up, go to the washroom. Probably better to have just a commode, bedside commode, easily reachable for clothes and other things. Same thing with bathroom. Faults are more common in bathroom. The slippery slopes. You need the rails. You need the hanging bars. Everything. The seat needs to be well adjusted because that's where you fall. Kitchen, same thing. Cooking is not easy. You need to have proper level of the appliances. Things that you usually need to have it right next on the counter, so it's easily reachable. Stairways. Probably not better to avoid the stairs if you can, but they all need to be looked through. Call your physician, have an occupational therapist come and they will check all the house and they'll give you the recommendation. Bathing, same thing. Shaving, grooming, you have to be sitting and doing that. As the tremors increase, get the electric shaver, electric toothbrush. There's a lot of things available, you just have to reach out for. Same thing, hygiene. Scheduling going to the washroom on a schedule, every 2 hours, 3 hours, that kind of helps. Avoid don't wait too long planning. Meal prep, same thing. Avoid sharp knives and stuff, hotness, and avoid too hot temperature in your for shower, things like that. Going back, okay. Dining. Same thing, they have different utensils, spoons and stuff, and plates where it doesn't move when you're shaking. Liftware is one of the products they sell online. Wearing clothes, loose fitting, easy, a little bit bigger size because you cannot reach out, and so you can try different fabric, easy cotton, 100% cotton, something easier. Shoes, well fitted, Velcro, because you can't tie the laces. Socks which are not slippery. Driving, that's a main one. They come and say, "Can I drive?" Early on, you can. Early stage, you can drive. But as the disease progresses, I usually recommend, you need to have a driving test, okay? There's places where you can have it. You can call your local DMV. AARP, AAA has resources. You can go to driving rehab specialist, call this number, call the driving rehab specialist 800 number. You can go see them. You can call Uber. You can have somebody help you out, friends, family. Traveling, that's a big one. Can I travel? Yes, you can travel, but you have to plan ahead, call the companies, and know where you're going, pack wisely, have the clothes, have extra medications, know where you're going, call them before. There's assistance everywhere, from the airports to the train stations to the buses. They have you can avail the early check-in. You can have wheelchairs at the airport, early boarding. If you have anything like equipment, wheelchair and stuff, they don't charge you. You can take still, if you have shots with medications, you can take them. Same thing, Amtrak, call them before, depending on your destination, where you want to go. Cruises, same thing. You can rent the wheelchairs. Hotels, call them before, see if they have accessible rooms. Give yourself extra time, always plan. Restaurant, you can go and eat, make sure they have the parking for the disability. Also, try the sit-down restaurants rather than the buffet. Dentist, you can have swallowing problems, so make sure you see a dentist. Sexual health, it can try Viagra. You can it can be side effect from medication or the Parkinson's, both. So if you're living alone, you don't have family support, you don't have a family of friends, you can always call the community support. You can always call support, make sure you don't isolate yourself, talk to your church, talk to your local organizations. They will always be willing to help you out and make new friends. Make a list. Like if you need help, you want to make a list of who you want to call. If you want to, if you're not feeling well, you need to know who to call to get your groceries. You need to know who to come and fix this and that at home. Who's going to take you to the doctor? Who's going to bring the medications from the pharmacy? There's a lot of ways now. Everything is online, so you can order it online. It comes right to your door. Just a little references from my presentation. I like this slide though. Robin Williams. You treat a disease, you win, you lose. Okay? You treat a person, I guarantee you, you'll win, no matter what the outcome. He also had Parkinson's, so did Muhammad Ali. Yeah, there's quite other celebrities, they did. So hopefully you learned something today. Again, thank you for the time. And if you have any questions, feel free to send it to me. Thank you very much.
Okay, Dr. Mundozie is on this class. There he is. Hello.
Hi, how are you guys?
Good. I'm going to unmute and undo my video. Hold on a sec. Oh, my host stopped my video. Oh, well, that's nice. That was more background noise. Sorry about that. I guess another video started playing. All right. Are there any other questions out there for Dr. Mundozie? It's very quiet. You covered so much information, Dr. Mundozie.
Oh, thank you. I know there's a lot of information, but it was, I think we could have done more, but, 45 minutes, the attention span is usually, they say it's 30 minutes, but we kind of stretched 8 more minutes on that. But thank you so much for inviting me, and hopefully it was beneficial. The key point is it's a subjective diagnosis. You need to talk to your doctor, work with the physical therapist, occupational therapist, speech therapist, which is the main one, which I believe there's another talk later on today, and the neurologist. So it was my pleasure. Thank you, everyone.
So do you work hand in hand with them, with PTs, OTs?
Yes.
To find solutions for Parkinson's folks?
Yes, because every patient is different. They might have other comorbidities like arthritis. They might be on different medications because it's kind of challenging to treat the Parkinson's with these medications we have. So it's a group effort really for any chronic conditions, and especially particularly with Parkinson's. So yes, we do kind of work together.
Yeah, no one has questions with me, I guess. So I work with a neuropsychologist who tries to define what's happening with someone's brain, and maybe the Parkinson's isn't prevalent yet. How do they figure out that it's Parkinson's versus just another neurological disease? Is that through like an MRI or a CT scan? How do you figure that out?
Parkinson's, usually it's a clinical diagnosis. So based on the subjective findings, the physical examination, but there's different things that are available. But that's like MRIs, PET scans, other imaging studies. Usually that's more involved when you are kind of not sure about the Parkinson's, or to rule out the other causes rather than to rule in the Parkinson's. So every patient is different, and that's why we use different resources for that particular patient.
Does MercyHealth have support groups for Parkinson's families, or do you recommend they go to the Parkinson's Foundation?
Mercy has some resources in Illinois. They do have some resources in Wisconsin as well. But there's a lot of resources available. Elderwerks would be a good one to call, get the resources available. You can call the senior services. We do have we have social workers in Harvard. They can help with a lot of resources. So yeah, it's just a matter of talking to your physician, family physician, and then they can direct the more resources depending on where you're living.
Well, thank you. Appreciate that. Let's see. Are there any questions? Yes? Oh, wait, we have one. Yay. Let's see. It says a lot of great information for treating Parkinson's and managing it, but any cures on the horizon?
That's the main thing. One of these chronic conditions where we don't have the cure so far, unfortunately, but there's a lot of effort, research in gene therapy and other, some of the MAO inhibitors that the people are working on, but still it's not FDA approved. So keep your fingers crossed, and hopefully we'll find a cure someday.
Yes, that would be nice. Cure for Alzheimer's, cure for Parkinson's, cure for cancer. We're working on a lot of things. It's going to take some years.
Cure for COVID too.
I don't think there are any other questions. So thank you so much for coming today. We appreciate your time.
Thank you.
All right, you take care.
Bye.
Bye.